talking about some tips and tools to support these families. And I told Dr. Shannon when we took a break, I says a lot of the stuff that you hit on and went really in depth into are things that I have in my notes of how do I approach these patients? How do we walk into these counseling sessions? What are we looking for when we walk into these counseling sessions? So let's just dive into it. So the first thing we do is when we go into that session, Marcella, I'm thinking about the question you asked. And, I go into these rooms at clinic and I know nothing about the patients because some of them I see their delivery notes, but that doesn't tell me their whole story. So when I walk in there, I start out with these open-ended questions. And my peer counselor who's here is going to go, oh no, not more open-ended questions. But you start out with open-ended questions. How are you doing? What can I help you with today? How are things going for you? And I listen to their story. I just sit there and I listen. And I listen. And I listen to this patient's story. And this is how I'm going to build trust with that patient. That's how we're going to get things going, because there was one thing that I read, and it was talking about, as Dr. Shannon mentioned, how patients don't want to see multiple providers. They want to be able to tell their story one time. And it said in this research, it said that a lot of times patients are not going to share that trauma, their experiences, because they don't know you. They don't have a relationship with you. And the best way to build that is to build trust. And as they tell their story, respect that story. Dr. Shannon talked about respecting them, hearing their story, hearing their boundaries. And while we're listening to their story, now that we've learned about trauma, letting it kind of play through your brain, what is this patient that's sitting in front of me dealing with? Do they have ACEs? Do they have intimate partner violence? What was their birth experience? And how is that going to impact how I work with that patient? Do they have that history of sexual trauma? And what about birth trauma? And this could be any event that occurs during any phase of childbearing that involves actual or threatened serious injury or death to the parent or child. It could be that parent that we've talked about who does this wonderful birth plan, and all of a sudden they want a natural birth, but they end up having to have an emergency C-section or cesarean for some reason. That's a trauma for them. Or maybe they ended up needing to use forceps or a vacuum with the baby. That's not that parent's goal. That wasn't her plan. So guess what? That's a trauma. Those are things that are going to impact how we help them with breastfeeding. They're things that's going to determine how we work with that patient. So we want to always be acknowledging that role that trauma has played in their life, in that relationship with their baby. How is it going to impact that? And then, what are their infant feeding goals? What are their plans? What would they like to do? How can we help them to achieve that? And this trauma may be experienced by us as well. If we see, Marcel, I'm sorry, I'm going back to your example again. But if we walk in, and my nurses that's here, you're going in to do your home visits. You're seeing these patients. And if you walk into situations many times over and over again, you do get some trauma yourself, which the tips that Dr. Shannon gave us are going to help us as we're walking into those situations and dealing with that. And one thing that isn't on the list, that is a trauma, what if that patient is displaced? And I think about flooding that we had in Haywood County a year ago. You had people that were displaced from their homes. They lost everything. How is that impacting that family? What is going on? So what is their story? What are they telling you? Maybe they've gotten evicted. What is going on? What is happening with that patient? There's challenges as we've listened to this story that we also have to think about. Skin to skin care, don't we talk a lot about skin to skin care, getting that baby right here skin to skin? But guess what? That skin to skin care may be overwhelming for some of our patients if they were abused. But they're like, I hear so many wonderful things about putting my baby skin to skin. How can we do that it's not going to cause trauma for our patients, not cause re-traumatization? Maybe if that parent has on a t-shirt and the baby has on a onesie, they're not skin to skin, but they're still there close. It's going to get that same sensation for that family, do that same bonding piece without escalating her concerns. What about they may not want to have something touching their breast, or the thoughts of baby being at breast is just overwhelming for them. That visual or visceral sensation of that mouth on the nipple is more than they can handle because it triggers things from maybe when they were child sexually abused. How can we help them to overcome that? This may be the person who does much better pumping because that's an inanimate object, or using a nipple shield as a barrier between them and the baby on their nipple. What about that PTSD from their birth trauma? And all of these kind of all go together. Sometimes they're at increased risk of having depression, depending upon what happened. If it was that traumatic birth, that they didn't get their birth dream, they're going to be grieving. That can lead to depression. That can lead to postpartum depression. And how are they interacting with that infant? When you walk into that room and this patient is sitting there, or walk in to do your home visit, what is the interactions that they have with that infant? Are they looking at that infant? Are they smiling? Are they interacting with the infant? Or is this that patient who is sitting there with that blank look, baby is nursing, and the parent is looking out off into the world, not engaging with that baby? Also, one of the things when we were counseling, I didn't mention these, I want to go mention them now. Some of the words that the patients tell us is going to give us an idea of what they may be experiencing or what have they been experiencing. And some of those words are things like, the delivery didn't go as I planned. I've got to make breastfeeding work. Have y'all heard that one before? And those are usually the ones that are what's struggling the very, very most. Or they maybe are saying, let me find it on my notes. I've got to get feeding right. Delivery was so hard. We've heard that one. I can't stand the thoughts of putting my infant to breast. We've all heard that one, right? Or breastfeeding is nasty. I can't see myself doing that. We're hearing those kinds of things from our patients, which is what's going to lead to our challenges. When we hear those things, we do a little bit deeper digging. We try to find out, is it because that they can't vision putting baby to breast? What is it to them that makes them think that breastfeeding is so nasty? What are those things? And once we can hear that story, we're able to help them through the process. Some of the things that really helps with the process, helps us to help our patients, and Dr. Shannon alluded to this, talking about education. The best thing we can do is to provide lots of prenatal education on breast or chest feeding. Talking to them about how after delivery, the standard of care is to have baby go immediately skin to skin, because if a patient hasn't heard that and baby's laid right here after delivery, what happens? They don't like that, right? They like to know that. So talking to our patients, doing education on the frequency of feeding. How many times have we heard a patient say, I didn't realize this baby was going to be eating this often or this much? We've all heard that, right? So education, education, education. And everything that I read on working with patients who've experienced trauma talks about the more education that patient has, the more informed they are. It gets to the choices that Dr. Shannon talked about. They're able to make their choices, and it helps to overcome any trauma that they have experienced. So knowing that most of you have interactions with patients during the prenatal period, I want to encourage you to do education. Another thing to do education on is baby behavior, our infant feeding cues. What is that baby telling you? Why is baby doing what baby is doing? Because how many times have you had a patient say to you, why is he doing this? Why is he crying all the time? What is going on? Helping them to understand those feeding cues. Another point of education, which isn't on the list, is talking to them about their breast, about their body, the changes in their body. Because a lot of times we're getting calls from patients that are engorged or patients who think they may have mastitis. And sometimes it's just normal. It's normal for that breast to feel lumpy after the milk volume has increased. It's normal for these things to happen, but they're calling very concerned. So the more education we do about baby behavior, what to expect after delivery, the easier it's going to be for that patient. Connecting them with a support system. If you know that they're on WIC, Kimberly, I'm going to pick on you, you're my peer counselor, is make a referral to the peer counselors. If my nurse family partnership people that are here know this person is on WIC, find out if they've got a peer counselor. If they don't, reach out to WIC and see what you can do to help get them signed up with a peer counselor for that support. A doula. In Buncombe County, we have doulas that are available to our patients, pretty much at no cost to them. That's a support system for them. And survivor services. I heard several of you mention survivor services. They do exist at Mission. And who was it shared the story about the patient who had the birth plan and they got all of the wonderful things that were in that birth plan. And the best way to make that happen is to connect them with survivor services during their pregnancy to make sure those happen. After delivery, we're going to do a breastfeeding assessment and support. Always, always, always ask that patient's permission before you touch the breast or the baby. Always ask that permission. A lot of times when they're seeing me, they're in the doctor's office, so they just kind of assume that's going to happen, but we don't want to go in with that assumption. I'm always now asking, is it okay if I take the baby and weigh the baby if the mom is sitting there set up to nurse? I'm always asking, is it okay if the partner is there? I'm saying, will you take the baby? Will you get the baby and weigh the baby? So that I'm doing pretty much hands-off counseling unless I absolutely need to do hands-on, because that respects that client, that respects where that patient is at. When we're doing that assessment, we're going to be looking at positioning, we're going to be looking at latch on, we're going to be looking at milk transfer, but we also want to be observing that interaction between that patient and her baby. We want to see how engaged are they. Is this that parent who's nursing and just getting through it with that kind of that grit? Because this is what I know my baby needs. And she's sitting there looking at the clock over on the wall or a corner just so she can get through that because she knows that her baby needs that breast milk. And this, in my case, would be a patient, I want to make sure they're connected to behavioral health. I want to make sure that they're talking to someone about what's going on. And I want to try to think of ways that we can get them into situations where they can start interacting and bonding with their baby and it be a positive relationship with them. And most of all, support their feeding decisions, support their choice because it is their choice. And what we're seeing is that if we provide intensive one-on-one support during the pregnancy as feeding is getting established, guess what? The more successful they're going to be, if they know someone is there. Those patients that I get that come in like within days after delivery, and I see them, like, I'm thinking about one family I saw like it a couple days after delivery. I saw them again a couple days later. I saw them again about 3 or 4 days later. When I saw them 3 to 4 days later, that mom had gone from being very depressed, very stressed, to I've got this. I can do this. And it's just because we were so intense with her between seeing her at her family practice doctor at OB and seeing that support that she needed at that time. We had her hooked into those support services that she needed. So let's talk about some specific situations. So you're going to have this patient who says, I do not want to breastfeed my infant. I do not want to give my infant breast milk. And you know, for some of that's tough to hear, right? Because we know what? Breast milk is the ideal food for these infants. It's going to provide everything that this baby needs nutritionally. For the first 6 months of life, we know it's going to give this baby tons of protection. Well, what we have to do is go, okay, thank you. I understand where you're coming from. Validate them. Validate their concerns, their understanding. Support their decision. Going back to what Dr. Shannon said, without passing any judgment or triggering any guilt with this patient. And make sure that we educate them, if this is during the prenatal period, they're telling us that, about engorgement. Because we know the body doesn't know that she's not planning to breastfeed, right? All throughout the pregnancy, that breast is getting ready to make milk. Those mammary glands are developing. So we want her to know that when she gets home from the hospital and her breasts start to feel full and are engorged, how do I handle this? What do I do? And nurses, I have heard stories from many nurses through the years who say, yeah, I had patients that I did all this education with. I talked with them throughout the pregnancy, and they got engorged and were calling me and saying, what do I do? You walked them through, well, you can do this, or you can put baby to breast. And what did they do? They put baby to breast and started breastfeeding. Yeah, so, you know, respecting them, listening to them, hearing their story is the whole key with that one. And we're going to have patients who choose to exclusively pump. I can remember years ago, we had a patient who wanted to exclusively pump, and she had one of our pumps from WIC, and she was pumping. And with WIC, we provide breastfeeding education, we provide breastfeeding support. And this peer counselor took it to that next level. She's like, that means every baby needs to be at breast. So instead of doing that respectful education and support, this mom who was exclusively pumping and doing a good job with it kept getting pressure. Come in and let me help you get baby to breast. Come in and let me help you get baby to breast, which was not that patient's choice. So again, acknowledge and validate that patient's choice. Respect their choice. And provide them with the education to help them be successful with their choice. Help them to do that. And I brought some pumps today. And the reason I brought the pumps is we want to find out what kind of pump is this patient using. If you have a patient who is pumping exclusively and you're like, that's great, how many times in 24 hours are you pumping? And she says, I pump every time baby needs to eat. And you ask some more questions, well, how is that going? How long is it taking you? How much milk are you getting? And you find out that this mom is using a manual breast pump. We need to get her set up because she's pumping 20 minutes on each side with a manual pump and getting 3 or 4 ounces, which is great. But we know all new moms are exhausted. They're not getting much sleep. So any of these stressors that she's dealing with are exacerbated by that. So connect her with the resources to get something other than a manual breast pump. If, the ideal choice with that patient who's establishing a milk supply would be our multi-user electric breast pumps, which if they're on WIC, call WIC. If they're still in the hospital or getting ready to be discharged or they don't have WIC, they can rent these from a lot of hospitals or other places, or making sure they have a good single-user electric breast pump to use. Then finding out how are they using that breast pump. I had a patient in this week who had a breast pump, and her baby was in NICU, born very premature. And I'm not getting much milk. It takes me forever to pump. I'm pumping for an hour. Okay, bells and whistles are going off because I know at an hour we're not getting a lot of spikes in that oxytocin and prolactin, so we're not going to be stimulating a lot of milk production. So we got out her pump, which she brought with her. I said, show me how you're using this pump. It was a single user pump. She was starting out on the expression phase instead of using the stimulation phase first. So we did some adjustments. We worked with the pump. We adjusted the suction. And within a couple minutes of her pumping, she started having a milk ejection reflex. And she's like, I never see this when I'm pumping at home. I never see this. So making sure they know how to use that piece of equipment that they had. Asking them if we're doing it over the phone. I'm thinking how a lot of us are doing things over the phone. Asking them, how does the suction feel? How do you have any nipple trauma? How does it feel? Are good questions to ask. Also finding out how that breast shield fits at the breast. We look at how does this feel? Is it a hard one? There's some now that are softer. How does this breast shield fit? Are they centering that on the nipple? Let me grab my breast model here. Are they centering this breast shield on the nipple before they start pumping? How far is that nipple being pulled down into that shield? I loved how one of our program managers at one of the WIC programs described it. It's like the nipple needs to be floating in that tunnel. What is happening? What is the milk output? And going back to that, how is that pump being used? Is it on that really strong suction, lots of cycles, strong cycles? We're going to see that tissue pulled further down in there. So talking to them about that. Also making sure they know how to do hand expression. We need to start teaching our patients how to do hand expression during the pregnancy. This way, if they get home right after delivery, day 3 or so after delivery, and they get engorged and it's the middle of the night and they can't get baby to latch on, or they're pumping and they can't get any milk to move out, doing hand expression is going to help that process, is going to help with that. And I gave you 2 videos that you can look at for your own education, but it's really simple. What I see a lot of patients do when they come in, I ask about hand expression. They say, well, I'm doing it, but I'm not getting any milk, so that means I don't have any milk, right? And you ask them to show you what they're doing, and what they're doing is they're putting their fingers right here on the nipple and areola and squeezing. They're not going to get a bit of milk out. None at all. So teaching them doing that gentle breast massage, then putting their fingers about a 1/2 inch to 1 inch behind that nipple and areola, pressing back towards our chest wall, compressing together and relaxing. And a lot of times what I'll do with patients to help them get that technique down is I will have them put their hands on their breast, and they'll still do it, but they can't quite get that rhythm. I will ask their permission and do a hands over to show them what to do. And they're like, oh, I've got it now. I see this. So teaching our patients. Also educating them about the storage and feeding of human milk. So this guidance here from the CDC that I gave you the links for talks about the milk storage guidelines, talks about how they can heat that. It's available in English and Spanish. So if you're seeing Spanish-speaking clients, it's available in English and Spanish. And then teaching patients how to do paced bottle feeding. How many times have you seen a parent who is feeding their baby, and this would work for this patient who is exclusively pumping and needing to give baby the bottle, and they talk about how baby's spitting up right after the feeding, or how when they're feeding baby they have milk just running out of their mouth and going everywhere. Talking to that parent about, and this is what they're usually doing, they're usually laying baby on their back with the bottle like this, right? What's happening with that milk in the bottle? Yeah, it's running out fast. It's choking the baby. They're trying to cope with that. Doing paced bottle feeding, and iAble has it in English and Spanish, so you can use that for both. And that's holding baby in an upright position, holding the bottle at this angle. And the question parents always ask is baby going to take in air? If baby's gulping really fast, they're taking in a lot of air. So no, it's not going to increase the air. And one comment, I think it was on the iAble education, it says that gas is going to come out one way or the other if they've got gas. So it's not that big of a deal. And when I've worked with a lot of speech and language pathologists, what they actually recommend is holding baby on their side as opposed to setting up and putting them like this, especially if we're thinking about transitioning to breast, which some of our patients that are exclusively pumping may be doing that. It helps make that transition a little bit easier, a little bit better. So if we've got this patient who is exclusively pumping, a lot of times we start to hear, my milk supply has dropped. How many times have we heard that? I'm not getting as much milk as I was. And that's a patient I talked to last week. They were pumping exclusively. Their goal was to get baby to breast, but they're like, baby was just a week, 2 weeks old, and it's like, but my milk supply has gone down. So the first thing you talk to that patient about is, how many times in 24 hours are you using that pump? How many times are you moving milk from that breast in 24 hours? And if we go down to that bullet that's the last one from the bottom, it's aimed for that magic number. This is the number of times in 24 hours that milk should be moved from the breast to maintain that milk production. Finding out how many times in 24 hours this patient was pumping, how many times is she pumping now, and what we may find is they go from 8 pumpings in 24 hours to 5 or 6 pumpings. Let's work with her to start to increase that back up to the 8 where she was getting adequate amount of milk. Sometimes we find it might just be 7. But helping her figure out, how do I do this in my lifestyle? Now that baby's home from the hospital, now that I've got other kids that I'm taking care of, how do we get these number of pumpings in 24 hours? If possible, or if this patient can tolerate it, skin-to-skin care with the baby. Also, making sure that this parent is pumping where the baby's at. I've had patients who have the pump set up in one room, like in a nursery, and baby has been downstairs with grandparent and partner or dad and mom's upstairs pumping, and she's like, I'm not getting any milk. And they're sitting in our office pumping, and baby's sitting right there in the car seat, and milk is just flowing. So thinking about those things, what can we do to enhance that milk ejection reflex? Deep breathing, relax, that relaxation techniques that Dr. Shannon taught us. What can we do to get relaxed? Quiet music, gentle breast massage, warm compresses. That's going to help us to elicit that milk ejection reflex. Doing some breast massage. If she sees that one side isn't flowing as fast as the other, she can gently take or hold these across the breast like this And then she's got this hand to reach up and gently massage that area that feels full to get that milk to move more. Having her do, when she doesn't see a flow of milk anymore, stop pumping, do some hand expression to get that flow started again, and then pump for a couple more minutes after that. I've got power pumping up here, but another way to think of that is intensive pumping. This would be where you talk to them about how can they increase the pumping, short time periods for a couple day time period, okay? So we don't want them, because you'll talk to patients who say, I sat there and I pumped for an hour. We don't want that. We want short 15 to 20 minute pumping sessions to get those spikes in that oxytocin level to help with milk flow. What can we do to get short pumping sessions in? Does it mean when there's a show on TV that she likes to watch, I watch the show and I pump while the show's on. When the commercial comes on, I relax. I stop pumping. And they do that for an hour, 2 or 3 times a day. Or if she's at home, if this patient is at home, wherever, and they're doing their chores like laundry, the dishes, the normal daily stuff, every time this patient walks by the pump, have her stop and pump for 10, 15 minutes, and then go on and do something else. That milk will be fine up to 4 hours at room temperature. Help her figure out, how can I do that? What can I do to increase that milk production? And self-care, because these patients a lot of times are doing it on their own. They're pumping to give the breast milk to the infant. They're feeding the infant the bottle. They're exhausted. They feel like that is all they do. They're like, but my baby has to have this milk. This milk is what my baby needs. Talk to them about self-care, making sure they're getting rest, make sure they're drinking fluids, make sure they're eating food, make sure they're consuming the calories that they need. And then we've got our patients who choose to feed the infant at breast. Those are the easy ones, right? We work with positioning and latch on. Sometimes, I saw you, Marcella, sometimes, but sometimes they have struggles that we have to work through. And we end up combining pumping with that. But we acknowledge them, we validate their choice. We let them know that we're here to support them, right? That we're going to walk this journey with them. If they come in, we're going to do a complete feeding assessment. We're going to find out, we're going to even ask some of these questions over the phone. How often is baby eating? How long does that feeding last? Is baby falling asleep within 5 minutes of being at breast and he's not gaining weight well? What is that story? How is the infant's weight gain? What's happening there? What about the baby's output? Is the patient experiencing any pain or discomfort with feeding? And we're going to get them connected with the resources they need if that baby's not gaining weight. What can we do, and who can I refer to get that counseling? If the patient is having pain, nipple or breast pain, dealing with a breast infection, how do we help that patient navigate that journey? And again, if we're needing to touch the breast or the baby, always asking permission before we do that. And then our last scenario is this support for the patient who is not able to feed the infant at the breast or the chest. So a couple of thoughts with that. This may be a patient that you have worked with throughout the pregnancy, and they have told you, you've done your education, and they're like, I am going to breastfeed this infant. And they have a trauma during this birth. Something happens, and they are not able to successfully put baby to breast. They're not able to provide milk for this baby. Here's a scenario. This patient throughout the pregnancy had planned to breastfeed. That was the goal. That was the dream. Got a pump, had all of the stuff that they needed. About a month prior to their due date, went to the hospital with some abdominal pain, and they were thinking, Okay, it's gallbladder. But nothing that needed surgery at that point. Did some care measures, sent the patient home. About 2 weeks later, the patient went back to the hospital, and this is now about 2 weeks before baby's due date. Went back to the hospital in severe pain, severe discomfort. They started looking at things thinking, well, it's the gallbladder. Well, that gallbladder was there resting and doing fine. She had appendicitis. So they had to decide, were they going to take out the appendix and then risk her going into labor in 2 weeks before all of the incisions were healed? Or did they do an induction of labor and after delivery remove the appendix? So that's what they did. And within 2 to 3 hours after delivery, she ended up having an appendectomy, and it had ruptured. And so the beauty of it was baby got to go chest to chest with her right after delivery. Baby did latch right after delivery and nursed. So she's got that memory, right? She's got that. Well, what happened is she got an infection because that appendix had ruptured. She got an ileus. She was trying to pump, but not pumping that every 2 to 3 hours that we talk about because she was very, very, very sick. I did counseling with her, and we talked, and at that point, it's like, okay, increase the number of times you're moving milk. Let's see if that helps to increase the milk volume. And after about a week of that, because she hadn't been pumping but maybe 3 or 4 times a day, if that much. And after about a week of that, she was exhausted. She was tired. She wasn't enjoying her baby. I said, stop. Stop. You do not need to be putting your job right now is to be able to enjoy your baby. And you are so stressed with all that's going on. Your body's trying to heal. And so that's what she started doing. She just started loving on her baby. And right about the baby's due date, no, a month after delivery, she had to have her gallbladder removed. So within a month, she had a baby and 2 surgeries and just was not able to produce milk, just was not able to fulfill that dream with that patient, right? With her baby. So we acknowledged her feelings. We acknowledged her fears. I mean, she was just stressed out. Provided support and encouragement for her. Talked to her, listened to her story, listened to her dreams, her desires. Realizing she's grieving, right? She's grieving what she wanted. She did have a good birth because they did the induction. It's just everything that happened after the birth went south. So she's going to have some grief. She's had some grief. Her mom was there, who is a former labor and delivery nurse, postpartum nurse, was there watching very closely for postpartum depression because this patient was at risk for that. We made sure that she knew how to prepare that formula. We talked to her about how to access formula in this current era that we're in. And you know, she's talking about when she has her next baby, that she is going to definitely breastfeed her next baby. So there was good that came out of that because we heard her. We heard her cries. We listened to her. We heard her story.